Our next speaker is Professor Imogen Mitchell. Professor Mitchell is the Clinical Director of the Australian Capital Territory COVID-19 Response and Executive Director of Research and Academic Partnerships, Canberra Health Services, Canberra, Australia. Dr. Mitchell will present on COVID-19 Lessons Learned in Australia.
Thank you, Dr. Kavanagh, and thank you for the opportunity to talk about the Australian experience of the global COVID-19 pandemic. Over the next 25 minutes, I hope to provide you some Australian context, particularly in relation to the healthcare system, the so-called timeline of events, which of course probably in retrospect wasn't the real timeline of events. Try and explain the governance of how Australia has managed the COVID-19 pandemic, and the breaches that we've experienced from hotel quarantine, which has led to some challenges in the aged care sector. And more recently, our experience with vaccinations and potentially lessons learned in Australia and potentially ones that we can still learn. So just to provide you some geography, as you know, Australia is wedged between the Pacific Ocean and the Indian Ocean, and where I'm speaking from today is Canberra in Australia, which is the nation's capital. Very few have heard of Canberra. It's a purpose-built capital, just like Washington, DC, and probably resulted from a little fight between Melbourne and Sydney, which are the two biggest cities which lie north and south of Canberra. Probably just to explain that the Australian healthcare system, which will help explain how some of the governance has been managed and sometimes has caused some challenges at the same time. It's really divided into two. There is a universal healthcare system, so people do not go without healthcare. The two sectors include that run by the federal government and then that run by the state and territories at the jurisdictional level. The federal government provides the major role in national policy making, but importantly funds the national insurance scheme, which is Medicare, which then goes on to fund drugs, public hospitals, population health schemes, the aged care, which of note, as you will see, is in a federal system, Indigenous health, the GP immunisation scheme, and the rural retention scheme. The state governments actually run the public hospitals, and indeed they deliver the public health services, which of course has been important in managing the COVID-19 pandemic. In terms of primary healthcare, which is quite strong in Australia, there are many practices around Australia. They vary in size, but they generally run as a private business and they are fee for service, so that patients can go there, but often are charged a gap, which means that they have to self-fund this gap with some remuneration from Medicare benefit schedule. There are rural healthcare clinics and community healthcare clinics. And as you will note, there is in fact a lot of doctors in Australia, but they tend to be concentrated in the bigger cities and often not in the rural and remote communities, which often lack medical support. If you look at the hospital-based care, it was also divided into two. There's the private sector and then the public sector, which is run by the jurisdictions, the states and the territories. The public sector, as you can imagine, manages most of the emergencies, and the private sector manages most of the planned elective surgery that is undertaken in the private sector. You will see that the number of separations between the public and the private is almost equal. And so it would mean that the public health system relies heavily upon the private healthcare system to ensure adequate delivery of healthcare, which means that if in a global COVID-19 pandemic, we needed the two systems to work very closely together such that there was a united response to the global pandemic. So when we look at Australia's response to COVID, we will see that Australia is a very large country, the same size as the United States of America, with a vastly different sized population of just under 26 million. This, of course, has been to the advantage of managing COVID in Australia because the population is relatively sparse. And there are some concentrated cities in Melbourne and Sydney, but really it has meant that we've been able to manage COVID a little more easily because of the sparsity of population. If we just remind ourselves of the timeline, and of course this timeline that I will show you probably will need to be rejigged in history because of course it probably is not correct. But this is the timeline that we were responding to at the time. If we recall, back in the very early days of January 2020, there were starting to be stories coming out of Wuhan seafood market of this pneumonia that didn't seem to have a disease entity that we could capture. And then, of course, there was the genetic sequencing very early on published by the Chinese, which probably has been critical in developing vaccines at a very early stage compared to most infectious diseases. But as time went on in January, we saw cases spread from China to Singapore to Hong Kong and then into Korea. And this, of course, meant that there was some concern that we were now seeing cases that were spreading human to human. However, very early on in the course, the WHO did state that there was no evidence that these traveling from person to person, which in some respects reassured us at the time. But as time went on, as we started to see the spread, and indeed the first cases in the United States of America, which probably, of course, was not the first case, there was increasing concern that we were starting to look at a pandemic. In Australia, we saw our first cases in late January. We started to see travel restrictions into Australia, whereby we were limiting those coming from mainland China. And by the beginning of March, Australia saw its first COVID-19 death. By late February, the Australian Prime Minister declared an outbreak, which would soon become a pandemic, and as such, activated the emergency response plan. This meant that the federal government had powers that they would not normally have. We started to see further restrictions in travel from Korea, and it was then deemed that any person coming from overseas would need to self-isolate for 14 days, and cruise ships were banned. And there was an increasing demand that people should not be traveling overseas. By the 11th of March, the WHO declared its global pandemic. And in Australia, we were starting to see concerns in cruise ships that were returning to Australia, whereby potentially people had COVID-19 symptoms, were disembarked without going into self-quarantine, and as such spread COVID around Australia, resulting in 11 deaths. Unusually for Australia, which although it is a federated country, the borders are freely open and not restrictive. But we started to see that borders between Queensland, Western Australia, Northern Territory and South Australia were all closing their borders to those that wanted to travel into them, so that they would also need to quarantine for 14 days. We then started to see a further shutdown of Australia, and by the 26th of March, we were now into a stage 4 lockdown. And anyone coming into Australia, and this has been in place since the 28th of March, that anyone coming in has to be quarantined for 14 days. And to leave that quarantine, there has to be a special exemption process from the public health that's relevant to that jurisdiction. The COVID-19 pandemic in Australia was following closely on the tails of a very, very difficult summer. We had bushfires all down the coast of Australia, on the east coast, on the south coast. And you could see from the graph, which demonstrates the air quality in Canberra, in fact, we had the worst air quality in the world. And then this was topped off in the nation's capital with a horrendous hailstorm, which impacted 34,000 cars and numerous houses with it. What this meant was that our well-being already was suffering, and then to go into a global COVID-19 pandemic was extremely challenging, as we weren't feeling particularly happy at the time. And what we started to see around the world was quite terrifying. And certainly seeing a Twitter feed from Italy, from Lombardy, where we know the health services are extremely high class, I was starting to see that pathologists and orthopedic surgeons were now looking after intensive care patients. And as an intensive care specialist, I was particularly concerned that we in Australia may not have the appropriate response in terms of could we actually cope with the huge number of cases that were likely to come towards us. The reason being, of course, is that a significant percentage of patients who develop COVID-19, certainly in the early days, were needing to be admitted into the intensive care unit. So up to 5% of patients who develop COVID-19 and 20% needing hospitalization. So there is no doubt that we were starting to see that health systems were overwhelmed in Italy, London, and New York. And seeing that from afar was really quite terrifying. And as I was seconded from the Dean of Medicine at the Australian National University to this COVID-19 response in my own local jurisdiction, I was avidly watching the data, almost obsessed by it on an hourly basis to see how many cases Australia had indeed developed. As Dr. Kavanagh pointed out, one of the advantages in Australia, although a federated country, there was very quick assembly of a national cabinet, such that there was national coordination of our COVID-19 response. This was informed by science because they had the Australian Health Principal Protection Committee, which was chaired by the Federal Chief Medical Officer. He had 3 Deputy Chief Medical Officers to support him, and indeed all the Chief Health Officers around Australia. So there was no doubt that science was informing our national cabinet. Very early on, there was also an acknowledgement that we needed to make sure there was going to be adequate COVID funding for any health response, and that was shared between the federal and the jurisdictional governments, and I think was really quite successful, ensuring that we did actually have adequate funding to support the resources that we needed. At the jurisdictional level, each one of the jurisdictions declared a health emergency. Each one of the jurisdictions was then coordinating its response through their Health Emergency Coordination Centre, and some of the jurisdictions divided their response into a public health response and then the clinical response, which would manage all the acute care facilities should the system get overwhelmed. The public health units in each jurisdiction, in effect, they're devolved, but they were very much guided by the National Australian Health Principal Protection Committee. And as plans were being developed, all the acute care facilities were planning for surge in a huge number of patients. If we look at the jurisdictional plans, there were public health strategies. And again, being a federated country, each of the jurisdictions had different public health resources and indeed strategies. But it's important to remind ourselves that they looked after the community movements, lockdowns, and indeed looked after aged care, hotel quarantine, and home quarantine. Each of the hospital facilities were developing their own principles, and in my own jurisdiction, we were looking at protecting our patients, protecting our community, and indeed protecting our staff. We were developing capacity plans for hospitals, looking at both infrastructure, logistics, particularly PPE. As we all know, in the early stages, it was quite difficult to capture enough PPE, particularly the respirators, and indeed the cost was absolutely phenomenal in terms of its increase. We looked at changing the models of care for workforce, and clearly we need to make sure that we had financial support to support these public hospital endeavours. One of the key strategies was also to improve communication both to staff and community so that everyone was aware of what was going on and what they needed to do to protect their own selves and their community. In my own jurisdiction, we were very aware that we had to deal with a massive surge of COVID-19 patients. And again, there was very strong agreement with little persuasion from the local government that we should fund to build a new emergency department that was designed according to WHO principles looking after airborne diseases, so that we'd have a new 56-bed emergency department where we knew that we'd have to manage the surge in patients. Thankfully, because we've had so little COVID in the Australian Capital Territory, this has never had to be used in the emergency department, but we have subsequently used it as a testing centre and more recently as a large vaccination centre, so it certainly has not gone to waste. So by the end of June, with the lockdown procedures, the hotel quarantine, the national governance informed by science, we really started to see the number of cases dwindle. We probably peaked at about 450 cases, which of course in other countries' terms is extremely small. But given the anxiety of having one case in a city, 450 was quite a lot. But thankfully, due to the lockdown measures, the public health strategies, Australia looked as if it was really starting to manage COVID-19 very well. But of course, there were many Australians who wanted to be repatriated, and they were coming from countries that were teeming with COVID. And so, of course, it is always likely that you're going to get a breach in the hotel quarantine processes. And as such, there were some strict strategies put in place and subsequently put in place as stronger strategies once we learnt what we needed to do. So as I've suggested before, any returning traveller has to quarantine for 14 days. Mostly they're in hotels, occasionally they're at home. They cannot leave their place of residence unless they are exempted to leave by the public health team. The vast majority, over 500,000, have returned through hotel quarantine, and they're predominantly based in Sydney, and Melbourne, and to a lesser extent in Brisbane and in Perth. The COVID testing has varied throughout the course of the 12 to 14 months, but probably more routinely, residents are now tested on the day that they arrive and just as they start to exit the quarantine, and must be negative before they leave the place of residence. The staff are now, and weren't previously, daily tested for COVID-19. And again, we've learned our lesson that there needs to be limitations of movement of staff because of the concern that they could be vectors for the COVID-19. Because we're a federated country, there have been continued variations in practice across Australia, and depending on what jurisdiction you're in, it will depend on whether you are transported to a medi-hotel if you're COVID-19, you're transported to a hotel, or you remain in place. It depends on where you arrive into Australia. And we certainly learnt our lesson. Because there have been breaches previously, we've had to get a review of hotel quarantine. And the recommendations that have come out is that we need to continuously reflect and improve our processes, and that we need to make sure that the returning travellers have appropriate information and appropriate escalation procedures. There was also a recommendation that there should be national facilities for hotel quarantine, and this has probably been enacted in the last few weeks. There was a breach of hotel quarantine, which led to quite a large, in relative terms, of COVID-19 in Victoria last year, where we then learnt quite a few lessons. What happened was that there was a breach in hotel quarantine, and then from the night manager gaining COVID-19, there were then some security guards, which of course then meant they were probably spreading it to the rest of their families. Initially, Melbourne tried to manage the COVID-19 spread by locking down a minimal number of postcodes in Melbourne, but it became increasingly apparent that this probably was not containing COVID-19. And it got to the point that New South Wales decided it would finally close its border, which it hadn't done previously, to Victoria. And this was the first time in over 100 years. The last time the border was closed between Victoria and New South Wales was the Spanish flu in 1918. And then there was also the instigation of masks as well as small lockdowns. And eventually a state of disaster was declared in Victoria in the beginning of August 2020. And it took 12 weeks before the restrictions were lifted. And this was a difficult time for Victorians because, of course, the rest of the country was starting to open up, and it made life very awkward for those living in Victoria, which were experiencing a very different time to the rest of Australia. So, as I say, a very different experience in Victoria, where there was lockdowns and very few people on the streets. There were daily briefings from the Premier, Dan Andrews. So, as I say, it was a very different experience to certainly what I experienced in Canberra, where we've never worn masks at all, which is unlike other major cities such as Sydney, Brisbane, and others. So with the stage 4 restrictions, the public health strategies, the strengthening of the public health response by having greater amount of contact tracing and testing, you can see that from July 2020 to the end of the year, the number of cases that were now being reported across Australia, and particularly Victoria, were now almost down to zero, which suggests again the public health strategies are an incredibly effective way of responding to an infectious disease, which of course should be no surprise to anyone. And you'll see that the total number of deaths that we saw at the end of last year in Australia was 908. So very small in comparison to other countries around the world. One of the challenges that we experienced, though, with the Victorian outbreak was the vulnerability of our aged care facilities, which of course we've seen around the world, not only in Australia. In Australia, the residential aged care facilities are of a variety of funders. Some are not for profit, some are for profit, and some are funded by government. They are, however, all regulated by a federal commission, the Aged Care Quality and Safety Commission, and so all should be accredited so that they can care for aged care residents. There are almost 2,700 aged care facilities around Australia, housing at least 200,000 vulnerable Australians. And there were some challenges that we saw in Victoria, which has given us some very strong learning points for the rest of Australia, and even in my own jurisdiction of the Australian Capital Territory. So once the COVID-19 breached into aged care, we saw that there were an increasing number of deaths. There were a large number of residents that had to be transported into acute care facilities so that they were safely cared for. And so, of course, as a result of this experience, there were some reviews both in the local jurisdiction of Victoria, but also nationally as well. And things that they found that needed to be strengthened was certainly leadership and management of the COVID-19 response. There needs to be much stronger infection prevention control, and there also need to be better communication strategies for families who are sort of sitting outside the aged care facilities, completely unable to know what had happened to their loved one. And of course, the other issue that was exposed was the fact that many of the staff, because they were so poorly paid at the time, that they would be travelling from one aged care facility to another. And of course, unfortunately, spreading COVID-19 at the same time. And so strategies to strengthen all of those things were put in place around Australia, not least because there was then a national report that reported very similar issues and suggested strengthening both leadership and particularly infection prevention control, such that now all aged care facilities must have someone on site who has adequate and proper training in infection prevention control so that they could protect their residents more strongly. So if we look at today's numbers of cases of COVID, 25% are still coming in from overseas, and you'll see that the number of deaths is still very low at 910. So in summary, I'd say that the COVID-19 response in Australia has been very strong, and that there has been proper listening of science and national governance to manage the situation. Vaccinations, of course, was our get out card, if you like. For many of us, we have family overseas, and it's been quite challenging, if you like, remaining in Australia without seeing our loved ones. And so vaccinations was effectively our way out. The difficulty has been that we are probably reasonably slow at delivering vaccinations. If you can imagine, we have a population of nearly 26 million. To date, we really have only administered about 5 million vaccinations. So of course, each vaccine has to have 2 doses. So what that has meant is that we're still very low down on the ladder in terms of effective vaccinations, which of course will mean that it's going to be slower being able to open up the country to international travellers, and indeed for the Australians to travel overseas. So that probably has been quite difficult experience so far. I think one of the challenges has been is that there is no immediate burning platform, although interestingly about 2 weeks ago in Victoria, there was a breach in hotel quarantine, although in fact, interestingly enough, the breach was in fact in South Australia, but the resident travelled back to Victoria. And with a sudden small surge in cases, there's been a rush for vaccinations. I think one of the other challenges is that we are split in terms of who is responsible for what. So the federal agency is responsible for delivering vaccines in aged care and disability, and there is no oversight of those numbers unless the jurisdictions start to really inquire as to how many have been vaccinated. The jurisdictions, of course, are then responsible for vaccinating the rest of the population, but are entirely dependent on the federal government providing those vaccines in the first place. And the difficulty that we have had is that there's been very limited supply. Initially, there was a small supply of Pfizer vaccine. There's been a larger supply of AstraZeneca vaccine because there's now some onshore production of that vaccine. The difficulty, of course, is that the AstraZeneca vaccine has had some issues, and that has certainly created some vaccine hesitancy. However, as I said, when we had a small outbreak in Victoria, one could certainly see a small surge in people wanting to be vaccinated. The challenge there, of course, is that there is inadequate supply at the moment to ensure that more people can be vaccinated. So I think overall, the COVID-19 response in Australia has been very strong. There has been strong leadership at the national level, and there has been a coordinated response. And at the jurisdictional level, there's been very little tolerance for any COVID-19 cases. So that even if we've had 1 or 2 cases, say in Brisbane or Perth, those cities have immediately locked down for 5 days to ensure that there is good containment, and then strong public health strategies put in place, such as mask wearing, physical distancing, and obviously very strong testing and contact tracing. So there's very little tolerance for COVID-19. It is certainly true that both the community and the politicians have been listening to science. And as I think there's been extremely strong public health teams, particularly in New South Wales, which of course is the largest state, and they have a very decentralized model. So even surrounding the Australian Capital Territory, we are in a relatively rural place. There is still a very strong public health team. And over the course of the 12, 14 months, one can see that all the jurisdictions have really strengthened their teams, they've decentralized, and they've made sure that the testing and contact tracing has massively improved since when we first started. Our public health strategies have definitely demonstrated to work, and I think that's very important for the community to see that it actually works. We've closed essentially our international borders. We've reduced in the past our indoor gatherings, and COVID-19 safe practices have really enveloped all of us, such that when I go to work every day, I fill in a digital health screening tool, and every restaurant or shop I go into, I have to fill in a contact tracing app for that particular venue. There has certainly been this sense of fear watching the rest of the world, and really the desire that we would rather not have the same experience that others have had around the world. And of course, we've had the data to support our hard and fast lockdowns. It would be said that we're probably still looking at others in envy that the vaccination rates are much better, but hopefully over time that will start to improve. So overall, I've been extremely lucky living in a place where there's beautiful places to run in, and really seemingly very far away from the destruction seen in other cities and countries around the world. And of course, I've had the luxury also to run along beaches where I have no fear of contact in terms of COVID-19. In some respects, I've been very privileged to live and work in Australia, and I've learnt a great deal about how national responses can indeed work. And so hopefully others might learn from the same too. Thank you.